Good morning, and thank you for being here. I'm Joe Ruffalo, General Manager of The Hill. We'd like to thank everyone for joining us in the room and online for our event today, Bang for Your Buck. Get the most from your 2025 Medicare drug benefits. I'd like to thank our sponsor, Alliance for Aging Research, for their support of this important discussion today. With major changes to Medicare prescription drug benefits in 2025, beneficiaries who hope to minimize their costs at the pharmacy counter need to stay vigilant in the coming months. What do you need to know for this fall's Medicare open enrollment period currently underway through December 7th? These changes, including a $2,000 cap on out-of-pocket prescription drug costs and a new program designed to help enrollees spread out their medication costs over the course of the calendar year, may look straightforward on the surface, but they come with some wrinkles. At the same time, Medicare is finished with the first round of drug price negotiations, but the method for how the program is determining the value of selected prescription drugs remains a black box. With the second round coming up, how can beneficiaries weigh in with policymakers? We're going to answer those questions and a whole lot more. But before we get underway, a few housekeeping rules, I guess. If you're in the room, please silence your phone. But we do encourage you to join the conversation online. You can follow us on Facebook, X, and Instagram at The Hill Events using the hashtag #TheHillHealth. And with that, I'm delighted to get the program underway. We're going to start the program with a brief video, and then I'll be joined on stage with Sue. Thank you.
Medicare Part D is an optional benefit that helps cover the cost of prescription drugs. Recently, Congress set an annual limit on Part D plan out-of-pocket costs. In 2025, the annual limit will be $2,000. Having an annual limit is helpful, but it can still be a lot of money to pay. Fortunately, another new benefit, called the Medicare Prescription Payment Plan, helps beneficiaries spread their out-of-pocket cost into monthly installments with no interest or fees. It doesn't cost anything to sign up or use this payment option. However, you must sign up with your Part D insurance plan at least 24 hours before you pick up your prescription. You can't sign up for it at the pharmacy counter. Also, you must sign up for the payment plan every year. You can do this at any time, including during open enrollment. Once you decide to participate, you won't pay anything when you pick up your prescription. Instead, you'll be billed later by your Part D plan and will pay in interest-free monthly installments. Talk to your Medicare Part D insurance plan provider to learn more and visit www.loweroutofpocketcosts.org.
Please welcome to the stage Sue Peshin, President and CEO of the Alliance for Aging Research, joining Joe Ruffalo in conversation.
Excellent. Well, thank you so much for being here today. It's good to see you.
Medicare Part D is an...
Or not. Maybe we'll watch it again. Can you tell us in the audience about Medicare open enrollment and what changes to expect, especially in the Part D part of this for 2025?
Absolutely. And I just want to give hats off to Adina Lasser. I'm going to do my best to channel her today. But everyone should know Medicare enrollment is happening now, and it runs through December 7th. And more than any other year, we're really recommending that current beneficiaries and those who are signing up for the first time pay special attention to reviewing their Part D drug plan offerings. And if you're a current beneficiary or you're helping somebody who is, this is the year to review your plans to make sure it's going to provide the best coverage for your prescriptions, also at your preferred pharmacy. And this is all for next year, for 2025. And that's because in 2025, beneficiaries can expect two major changes in their Part D drug plans. The first is a $2,000 cap on out-of-pocket costs for prescription drugs, which is huge, and that will make a big difference for beneficiaries in terms of their affordability. And the second is something called the Medicare Prescription Payment Program, which we saw in the video, but it's going to require a lot of education, which is why we're repeating it again and again. And this new program is going to allow beneficiaries to smooth their out-of-pocket costs into monthly payments throughout the plan year, like a lot of people can do with their gas bill, but you were never able to do it before with your prescription drugs. And there's no interest or fees, and that's especially helpful for folks who experience high levels of cost at the outset of the year before you meet that $2,000 cap. And there's a few things we wanted folks to know so that they get the most out of the program, and I'm repeating some of the stuff that you saw in the video, but it bears repeating. You have to sign up for the Medicare Prescription Payment Plan directly with your Part D insurance plan, and you have to do it at least 24 hours before you pick up your first prescription medication at the pharmacy. You can't sign up at the pharmacy counter. It has to be through your plan. And you have to sign up for the option every year. Once you sign up this year, though, you're good for 2025, and you can do it during open enrollment or any time throughout the benefit year. But you're not automatically re-enrolled every year. And then after you enroll, you don't pay anything at the pharmacy counter. Instead, you're going to receive a monthly bill from your Part D plan, and it'll spread those costs out for the remainder of the year.
It's great.
Cool stuff.
Well, where can folks go to get more information on this?
Absolutely. So a little bit of self-promotion.
Please do.
We have a new resource at loweroutofpocketcost.org, and that's where you can get the video that you viewed. We have it in a slightly longer format. We have it in a 30-second PSA format. It's free, downloadable. We have it in English and Spanish. And we also have a social media kit if your organization or if you're in a Hill office and you want to spread the word to help a lot more people. So again, loweroutofpocketcost.org. The next is the State Health Insurance Assistance Programs, and we're going to be hearing from one leader in Maryland today, which is great. SHIPs, for short, offer free, unbiased, one-on-one counseling on Medicare options, enrollments, and changes. And it's a really valuable resource for personalized guidance. And again, completely unbiased. You could go to shiphelp.org and click on Find Local Medicare Help. And the last place you can go is Medicare.gov. But Medicare.gov is actually where a lot of brokers go. So for some folks, it can be a little harder to navigate, but it really is the most comprehensive source for information on plans, benefits, and costs. And the Plan Finder tool is useful for comparing options.
So Medicare just finished the first round of drug price negotiations, but there seems to be some murkiness around exactly what that all entails. Can you tell us about a recent report you had just put out that goes into a little more detail about the value there?
Yeah, absolutely. So CMS really, the Centers for Medicare and Medicaid Services, hasn't really said much about how they're valuing the medications that they've selected for direct negotiation. And we know that traditional methods of value assessment, or how we value medications, are generally, they're considered discriminatory by the National Council on Disabilities and by a lot of patient organizations. And Medicare's not allowed to use them as part of the Affordable Care Act. They were banned from using what are called quality adjusted life years, or QALYs for short. So the good news is we think Medicare really has the opportunity to be a leader in this space, especially because they've stated they're looking at real world evidence. And what real world evidence is data that's taken from real people who are actually using the drug. So after they've already gone through FDA approval and the clinical trials, what's happening in the real world? And that's not usually used a lot of times in value assessment. But the question is, what are they using, right? So we thought it would be interesting to work with Milliman. And I know we're going to hear from Bruce Pyenson, who's a very well-known actuary. He was on the MedPAC for a couple of terms as their lead actuary. And they helped us to come up with a sample framework. And it was called SOLV, SOLV, which stands for the Standard of Living Valuation. And it's a new approach to assessing value that connects socioeconomic factors, so basically standard of living, income, and also, other types of factors in your life that have an influence on your standard of living, to health outcomes. And standard of living is known to play a significant role in determining health outcomes, but traditional methods don't really use those. And unlike the QALY, it doesn't size up the individual based on how old they are or what kind of condition they have or disability that they have. So it's not discriminatory. So what can folks do to weigh in, on the process? As we go into the second round of negotiations, which is going to happen, at the beginning of February, beneficiaries can really advocate for the use of other types of patient-centered frameworks like SOLV. We're not saying it's the only way to go, but it's a great way that is not discriminatory, and it ensures that the unique needs of older adults and people with disabilities aren't discounted, that they're considered in the process. And we also want to see beneficiaries and more disease advocacy organizations participate in the listening sessions. Medicare's already said that they're going to be continuing these listening sessions next year. We want to see more diversity. in the types of groups and actual beneficiaries that participate. And then we want folks to contact their policymakers. And you can do that through organizations like ours at agingresearch.org. You can work with PAN Foundation, coalitions. We organize a lot of groups together, and we really want groups to get involved.
That's wonderful. With that last minute, is there anything else you'd like to reinforce for the audience?
Absolutely. We just really want to make sure that folks check out their formularies in their Part D drug plans. As you know, I mentioned before, there's likely to be a lot of changes. Some of them are really good, like the out-of-pocket cap and the Medicare prescription payment plan. But there's also a lot more that the Part D plans, the insurance companies have to pay into the Medicare program starting next year as a part of drug pricing reform. And as a result, we're worried that there's going to be a lot more what's called utilization management. So messing around with people's formularies, maybe not having the same drugs that you usually take on your preferred list. So, you know, they might switch up the medication on you. They might ask you to try a different medication before the one your doctor recommends. That's called non-medical switching. I take care of my mom. She notices when a pill looks different from what she's used to taking. That can cause confusion and worry. So we really want people to check their plans this year. If you do nothing else, don't get caught off guard.
Well, thank you very much. A lot of really important information.
Absolutely. Thanks for having me.
Absolutely.
Good
Thank
to see
you.
Last week, The Hill's editor-in-chief, Bob Cusack, sat down with our first guest, Bruce Pyenson. He's a former principal and consulting actuary at Milliman and former MedPAC commissioner. Take a listen.
So, Bruce, you have a new report out commissioned by our sponsor, the Alliance for Aging Research. It looks at a new framework for quantifying healthcare value. Why do we need a new framework? And tell us a little bit about this report.
Sure, Bob. The term value is used all the time in healthcare, and it means a lot of different things. But from our perspective, we're trying to come up with a notion of a value that reflects the comparison to of the underlying usefulness of a technology or a service in healthcare, so that a buyer, a payer, a government entity, or public health agency can say, this is high value or something else is low value. So there's a pressing need for this because the existing structures for value have been criticized with good reason as being discriminatory and inconsistent and mathematically awkward.
And why is that? It's always a tough thing to do, right? Putting a value on quality and value in years on your life. What have been the justifiable criticisms that you and the other authors have said, maybe we need to look at another way to do this?
Well, the foundation for what health economics does is transactions between individuals and the choices, the preferences that an individual has in a theoretical kind of setting. For example, the choice might be, would you rather live 2 years in perfect health or 4 years in a wheelchair? And of course, these kinds of surveys and these kinds of choices are hypothetical, and the kinds of results that come out of those don't make a lot of sense. The various tools that are used are often conflicting with one another. And as we know from behavioral economics, that people have other reasons for making choices. So economists often consider real human beings to be irrational. So we need a different framework than the one that health economics has relied on. It's called quality adjusted life years. We could get into what that means, but we need a framework that reflects what society actually does and what it what it values.
Right.
For example, uh, an economist might argue, well, uh, what's uh, what's the right price for throwing a life preserver to your dying child if you have a life preserver? What would the parent be willing to pay? That's a classical economic kind of transactional notion, a willingness to pay argument. But our society and any society that we probably consider civilized doesn't do that. We do things like have broad programs for swimming pool safety. We're training lifeguards. We're training people, teaching people how to swim. Or we have programs and spending for people who are severely mentally or physically disabled, whose quality of life might be very low. We do that as part of the fabric of society. And what we're proposing to do is to look at how real healthcare outcomes change based on standard of living, and to use standard of living as a metric to set value on hopefully improving outcomes.
And is there a chance that the government will shift? And should they? Looking at your framework, it seems like you got more nuance and comprehensiveness.
Well, thank you. The classical uh, health economics framework using QALYs is not has not been adopted in the United States by government agencies, and in fact, there's strong opposition to it uh, because it does discriminate against older people or people with disability.
Right.
So happily, the US government hasn't adopted that approach, but still it is, there's a pressing need to put some rigor on value. Uh, uh, you People hear the term all the time, and unfortunately, uh, it can mean a lot of different things to different people.
And how does the Inflation Reduction Act fit into this? I've covered healthcare for a long time, came to the Hill covering healthcare. And as you mentioned, different agencies deal with different things, and then you deal with different agencies on cost effectiveness and reimbursement. The Inflation Reduction Act, I mean, basically was an effort that was decades in the making as far as the healthcare component of negotiating prices, and it finally got into law. Tell us a little bit about that and where you think this part of the IRA is going.
Oh, well, in my opinion, the IRA is, as you said, long overdue. And the negotiation of drug prices is something, in my opinion, that the industry can manage. And although you hear a lot of complaints from the industry and its spokespeople, uh, they will manage with that. Everything else in Medicare gets its fees set, whether it's surgeons or uh, advanced imaging technology or hospitals. So the 10% of spending that's drugs is now becoming part of the rest of the Medicare program, and I think that's a good thing.
Uh-huh.
Uh, uh, the the issue of value is really, I think, more fundamental and will start to come up more and more as we look at the outrageous spending of the on healthcare in the U.S. economy. We are spending close to 20% of our gross domestic product on healthcare. Our outcomes by almost all measures are worse than any other advanced country, or certainly than the average. So the spending on healthcare is actually uh, making health worse in the US in the following way. It turns out that health care itself, medical care, is not the biggest determinant of how healthy people are. The biggest determinant of how healthy people are is their standard of living and their education and their housing, their wages, their opportunity for recreation, transportation. It's those socioeconomic drivers that are much more important for health outcomes. And as we spend more and more in healthcare, there's less to spend on these other items that are actually more important for health. And
You
that
mean like other countries? And when we say we're not getting bang for our buck, basically, is that what you're saying? The outcomes are not that good? When you were coming up with your framework, did you look at other countries or learning lessons internationally that other countries and say, hey, well, they do it better?
there's lots of other studies that have looked at that. I mean, a huge number. What I have identified as a key difference in the US and elsewhere is the role of intermediaries, middlemen, and the Inflation Reduction Act does take some steps to identify those, but I think that's a broader issue, perhaps a topic for another time.
Where do you see the future of the IRA and these Medicare drug provisions? Obviously, Republicans are not fans of the IRA. I think they want to repeal it, no doubt about it. They've already voted in Congress on that. But in both the energy and healthcare sector, it's hard to take away benefits. We saw that with the Affordable Care Act, and some Republicans are saying we can't repeal all of the IRA, but also then because there's only a certain amount of drugs that are being negotiated, where do we go from here in the years to come?
I think it'll take its course. The industry has, in my opinion, plenty of opportunity for innovation, and I think the whining that I hear about if you don't let us charge as much as we want, we're going to stop innovating. The role of the industry in documenting that, and in fact, its role in innovations doesn't stand up to scrutiny. And I think I'm enthusiastic about the medical breakthroughs that are coming, and I think they will still come, and we'll have the benefits of those. But right now, um, we're not seeing the benefits in longevity or health outcomes. Our health outcomes are worse. Uh, so, so I would challenge that issue. Perhaps a different question is if we are going to uh, have monopolies or oligopolies in healthcare, which is an emerging trend, how should they be regulated? We have utility regulation as a basis for other kinds of monopolies, the electric, gas, things of that sort. Perhaps not ideal, but uh, if that's the direction that the healthcare system is going with, we need a different way to regulate it.
Well, 2025 is going to be a big year because of the IRA and all that we've been talking about. But regarding prescription drug benefits, people watching this, there are healthcare experts watching this, but also just normal people who want to know what to do in the new year. What would be your advice?
Well, there's, I think, scrutinize the different options, and the big issue facing Medicare beneficiaries is whether to join a Medicare Advantage plan or not. And over half already have, half of the people who are eligible. So to understand what that might mean for uh, the kind of choices that you have going forward. I think there's certainly reasons to think about traditional Medicare fee for service, and there's also advantages in the Medicare Advantage program. There's general acknowledgement that Medicare Advantage is being overpaid by a lot. And I recently completed 6 years as a commissioner on MedPAC, the Medicare Payment Advisory Commission, has been very has had very interesting and clear analytics on this. So the question we're going to face is, are we going to continue to, in effect, subsidize the Medicare Advantage industry and watch people get pulled into that industry because they can afford perks, or is something going to happen to reduce those overpayments? So I think that's going to be the big issue unfolding. Uh, it's navigating the healthcare system in the U.S. is not easy, whether in the commercial world or in the Medicare world, and that's something that hopefully will get better in the coming years.
Yep, absolutely. Going to be a big policy-making year on Capitol Hill next year, whether it's healthcare and Medicare benefits and others. Bruce, thank you for your insight. Thank you so much for joining us today.
Well, thank you very much, Bob. Look forward to talking to you again.
It is now time for our panel of experts. Please welcome to the stage Tom Cornfield, founder and CEO of Mast Health Policy Solutions, Amy Niles, Chief Mission Officer of the PAN Foundation, Dr. Gary Puckrin, President and CEO of the National Minority Quality Forum, and Julia Schreiber, Program Director of Maryland Department of Aging and Administrator of the Maryland State Health Insurance Assistance Program. They are joined in conversation by Editor-in-Chief Bob Cusack.
Okay, so two great discussions set us up for this panel. We can delve into a lot of issues, but why don't we go down the line, Tom, starting with you. There's a saying in journalism, don't bury the lead. So if you can have a short intro, and what's your lead of the day? What's the one takeaway you want the audience to take away from this discussion?
Do you mean the discussion just generally around the changes for next year? Or
yeah,
what?
Just whatever you think is the most important thing to convey.
Well, I think that the most important thing to convey is the benefit is changing tremendously in terms of the out-of-pocket cap, and I think we heard about the monthly prescription payment plan, or MP3, it's sometimes called, or M3P. I forget what the right acronym you're supposed to use is, but it's basically an installment plan, right? And I think that protection for enrollees, I think, is one of the major changes for next year. The other, I think, is just given there were a whole lot of other changes in the benefit without going into a lot of details on it. Essentially, plans are at higher financial risk for their costs than they were this year. So that has led, I think, to a lot of changes in terms of plan availability, in terms of the premiums. So I think that's where it's really important for folks, as I think we heard earlier today, to shop around and make sure that they're looking for, whether or not their medications are covered, and also, what their premium is.
And a little bit about yourself.
Oh, I'm sorry. So I'm Tom Cornfield. I'm the CEO of Mast Health Policy Solutions. I spent about 25 years working on Medicare Advantage and Part D policy. Spent 10 years at CMS, where I was in charge of the division that did, for some of that time, that did Part D payment policy. Worked on the implementation of the Medicare Modernization Act in Part D, and have worked on risk adjustment payment policy for quite some time, and also spent some time at AHIP in Avalere.
Hi, everyone. I'm Amy Niles. I'm Chief Mission Officer with the PAN Foundation. The PAN Foundation is a national charitable foundation and healthcare advocacy organization, and we are here to accelerate access to affordable, equitable healthcare. We do that in three ways. The first is providing financial assistance to individuals who are underinsured so that they can start and stay on treatment. Secondly, by advocating for patient-centric policy solutions like the Medicare reforms that we are talking about today, so that we can enhance access to care for Americans. And finally, educating patients and healthcare providers about very complex issues and how to navigate a very complex healthcare system. I think one of the key messages today is the importance of open enrollment. There never has been a more important time to evaluate one's plan. We have about 2 million plus seniors who are facing plans that are no longer going to exist in 2025 or major changes to their plans. So it is really important for people to take the time. And we know that for the most part, 7 out of 10 seniors are not taking time to review their plan. So that is an important message. At the PAN Foundation, we did a national poll of people on Medicare about 2 months ago, and we found that 9 out of 10 individuals were not aware of either of the two reforms today. The Medicare Part D cap, which is automatic, that's an easy thing. People don't need to do anything, but the Medicare prescription payment plan, and that's a mouthful, and we used to call it M3P or MP3 as well. But the Medicare prescription payment plan on the surface sounds simple, but it is complicated, and it may not be for everyone. But during an open enrollment time, this is the time for an individual to evaluate whether the Medicare prescription payment plan is right for them.
Gary?
Good morning. I'm Gary Puckrin. I'm president of the National Minority Quality Forum. We are a research and education group based here in Washington, D.C. I'm going to say a lot of discordant notes for you this morning. I'm sorry. I don't believe in government price control. I went to college. I took one eco course. I hated it. But the only thing I got out of that eco course is government price control brings a whole set of problems. And that's what we see in the Medicare program. Medicare does not follow the science. In healthcare, everybody has to follow the science, right? You go to FDA, you got to show safety and efficacy. You come out of FDA, you got your drug to the marketplace, and then CMS flies in with a set of rules that are not associated with safety and efficacy and outcomes for patients. In fact, CMS doesn't even tell you about the outcomes of policies that they make. So let's dive in a little bit on this smoothing. This is what we call this loan. So I grew up in the hood, right? And so we had these loan stores in our community. And so the first question you have to ask yourself is, so what happens when you don't pay the premium, the loan back, right? Because as I read the law, and you guys can go take a look at the CMS rules, they stop your medication, right? So that's what the rule says. Now you can go read it. They stop your medication until you pay the premium, until you pay for the drug, right? So here you are, an individual, you've got cancer, very expensive drug. Somebody comes and says, hey, you can get the loan, right? You go get the loan, and the bill comes due, and you can't pay for the medication. And what happens? So what CMS has done, because to take the risk out for the plan, they gave them $5 billion. I mean, that's what I read going on. So here's my point. My point is, we have to begin to back CMS out of the marketplace in healthcare. We have to figure out, how do we do what Americans do, have a competitive marketplace in healthcare. I know that sounds really difficult and contrary, but I think that's the way we got to go. Because at the end of the day, we're spending $4.5 trillion a year in healthcare. That's the number, $4.5 trillion, which is larger than the GDP of Germany. Larger than the GDP of Germany is what we're spending on healthcare, and we get poor outcomes. So anyway, I'm just giving you my discordant note that it's time to reimagine the system because the one we got is completely broken. Thank you.
Julie?
So I'm Julia Schreiber. I'm with the Maryland Department of Aging, where I'm the program director for the State Health Insurance Assistance Program. We help beneficiaries, their loved ones, families, and caregivers navigate the complexities of Medicare. We're also the Senior Medicare Patrol, so we help beneficiaries navigate Medicare fraud, errors, and abuse. And we do this through partnerships with local area agencies on aging throughout Maryland to provide that localized counseling. And I would just reiterate, and every year we say to beneficiaries to review their annual notice of change that outlines how the plan might change from year to year, and to connect with a counselor if they're interested in seeing what other options are out there. And then I would also just emphasize asking and looking into financial assistance programs, because there's a lot of programs out there that can help cover the cost of Medicare that are actually underutilized.
Amy, I want to go to you. You've done a radio tour in New York City trying to reach patients on this topic. What did you learn?
Continued lack of awareness about the reforms. I mentioned our poll, 9 out of 10 people on Medicare throughout the country not being aware of either reforms. And I heard similar comments on the 26 interviews that I did with radio stations throughout the country. But regardless, it was an opportunity to educate. Again, the Medicare Part D cap is automatic. And if you are someone living with a serious illness or illnesses, and you've been historically used to very high out-of-pocket costs, that $2,000 cap is welcome news, albeit it is still quite a bit of money for many Americans. We did research at the PAN Foundation a couple of years ago to validate that even helping millions of our seniors and people on disability, it is still going to be a struggle for many communities. The Medicare prescription payment plan is important. It is not for everybody. It is not a loan. It is an opportunity to spread out the cost throughout the benefit year. And if someone unfortunately cannot pay that bill, we're encouraging them to make sure they are paying their premium first to keep that drug coverage. And so we're trying to simplify the Medicare prescription payment plan because it's complicated and there are behavioral changes. So someone needs to do something to benefit from the payment plan. They need to call their Part D plan, or they need to go onto their plan's website to take action to participate. And the best time to do it is now during open enrollment, so that you have more months to spread those costs. And secondly, if someone opts into the program, they're not going to pay for their prescriptions at the pharmacy counter. And that's a big change for people on Medicare. They're going to get this bill from their Part D plan. So there's a lot of nuance to this and education that is needed.
Julie, just want to get kind of the same question. What's the feedback you've gotten in Maryland? What's the best way to reach seniors? My dad's on Medicare. And unless maybe there's a commercial during a Mets game, he's not going to really be paying attention. But what are the successful strategies that these stats about 6, 7, and 10 don't know what's going on? That's daunting.
Yeah, so through the State Health Insurance Assistance Program, we do a lot of outreach. We partner with older adult housing facilities and go and do presentations there, senior centers. So there's a lot of just education and courses that happen in partnership with some of these other facilities where older adults are already congregating. And then, there's a lot of Medicare Advantage marketing out there. So just doing some of our own media outreach, whether it's bus wraps or radio interviews. In Maryland, we're also partnering with 211, which is our Maryland Information Network. And so they are regularly interacting with a lot of Marylanders, and it's another way to get the word out. So it's finding those places where people are already going, educating some providers and people that are already sharing information about some of these changes so they can share the information as well.
Tom, you're an expert on Medicare Advantage as well as Part D. What are you watching for these programs in 2025? Also, noticed you had a few head shakes from what Gary was saying, so I want to give you a chance to respond.
Well, I mean, I do think there's, again, there are a lot of changes in terms of what plans are going to be offered. So I think 7% of Medicare Advantage enrollees are in plans that will be terminating this year. So there will still, I think for most of them, there will, and my parents actually are in one of those plans, as it turns out, because my mother sent me one of the, the picture of the notice that she got, and she's like, "Did you expect this?" I'm like, "Well, I heard that it was going to happen. I didn't know, it was going to happen to you, but, I had heard that, there might be some disruption." So, there's that. There's also, as Amy was talking about, there's 2 million some odd people in plans. I think a lot of them are in some of the larger standalone prescription drug plans that are they're actually moving their folks into I think in CVS. So it's CVS and United, and CVS is moving folks, I think, from their enhanced plans, which were sort of the there was one plan that had a low premium, one plan that had higher premium. They're moving them into what's known as a basic plan, which is kind of the standard Medicare coverage. And then there's United that's moving folks from one of their plans into another plan. So they're going from 2 plans to 1 plan. So, absent any action, those folks, I think, will roll into that new plan. So I think that's where it's incumbent upon folks to, Medicare.gov allows you to look at, premiums. I know it can be, there can be challenges, but nonetheless, I do think it's a really important tool for folks to use. No, I mean, my understanding, I guess, just kind of going back to some of the comments earlier, on the availability of drugs. I mean, I don't believe you can be. My understanding is you cannot be disenrolled from you can confirm. I'll look at Amy and see if it's right, but you cannot be disenrolled from your Part D plan for failure to pay your copayments. Now, in terms of not getting your medications, I suppose, if you're not paying your premiums, then there's a process by which you can be disenrolled. And that's not new. That's been there since the start of the Medicare Part D program. So I just kind of did want to push back on that a little bit. It's not true that you're not going to be able to get your medications if you're not paying your copayments. The plans will try to, collect that information, but one of the concerns that I've heard from the plan side actually is concerns around bad debt, because they're concerned that they won't be able to collect that information potentially, and will have to write it off as bad debt, and that could impact their premiums. I think the other thing that has kind of been in the news in the last week or so, a couple of the major Medicare Advantage plans have noted, the challenges in terms of what their healthcare costs have been relative to what they were expecting them to be. So I do think that there are going to be pressures, and I think we heard Bruce talk about concerns around overpayment. I think that's going to continue into next year, and obviously with the tax cuts expiring, and I think there's going to be an environment where folks are going to be talking a lot about kind of Medicare Advantage payment within the policy realm. But I think for enrollees, again, the most important thing I would say is to really look at your plans, shop around. If you don't take action, there's a possibility your premium can go up just because you haven't taken action. And of course, you would have gotten something in the mail about that, but I understand, folks get a lot of things in the mail, so that can be pretty complicated.
Gary, to you, I know you're a critic of the IRA, but as far as reaching people and telling them, educating them on these choices, what's the best way to get, whether that's in urban settings or low-income beneficiaries, to reduce the health disparities?
So I just want to be clear on what I said. So as I read the rule about the smoothing program, you get a bill and you have 15 days in which to pay. If you don't pay it in 30 days, you're cut off from that medication, not disenrolled from the Medicare program or the prescription drug program. It's that particular medication you cannot have access to until you pay the bill, right? And I'm not a lawyer, so I'm happy to have someone go take a look at the rule. But as I read the rule, if you don't pay within 30 days, then you're subject to lose access to that medication. Now, you may not want to call that a loan, but if it quacks like a duck and it walks like a duck, it's a duck. And that's the way I look at it. And the reason why I'm saying this is because in the moment of stress, people sign a lot of different things, right? They sign a lot of different things, particularly poor people. And if they can't fulfill the pledge, you got to understand the consequences. And so I'm happy to be wrong and love it to be wrong, but I think people have to understand deeply when they sign that piece of paper what that means to them and their access to the medication. On the $2,000, obviously, wonderful to have. But let's bear in mind that the average household income for a Medicare beneficiary is $25,000, right? And when you add up all those 20%, you go to your doctor, you pay 20%, you go to the hospital, you pay 20%. When you total that up on average, that's somewhere around $7,000 or $8,000 a year that a Medicare beneficiary, at least in fee-for-service, has to pay out of the household income of $25,000. So yes, you've given them $1,000 back. It's a wonderful thing, but that program is really burdensome, right? It is burdensome, particularly for poor people, because it's not means tested. So you're the CEO of Apple. You pay the same thing as the janitor. Come on, guys.
Well, there are low income folks that are on low income do receive assistance with their cost sharing.
Absolutely important. I think that's an important part of the program. I would expand that.
They did expand it in the IRA.
I would expand it even more, right? Because we have to means test it so that getting quality health care is not a burden to people. That's the point. It's the outcomes that we're trying to drive towards. And the system right now is rationing care.
But it was rationing it. I mean, I think if we're talking about the IRA.
I'm talking about healthcare generally.
Right, I know, but we're here talking about the IRA.
Okay.
I mean, and I think if you're talking about rationing healthcare, I think prior to the IRA, there was a situation where, and I was on the discussion with folks that have been, involved in legislation, and from my understanding, folks were calling, senators' offices saying, I can't afford my medicine, I have to, they were going without medicine, splitting their medicine. So that's rationing by another name. So if we're talking about the IRA and in terms of, and I granted there are, pros and cons. I don't mean to say that it's all, in one direction or another. But if you're talking about rationing, I do think that the IRA at least helps with that piece of it by making it affordable for people that had their medicines that were unaffordable. So I do think that's important to acknowledge.
I just add that there's no question that $2,000 is a lot of money for a lot of people, but I think this is a step in the right direction. And yes, we can do more. We can do more for people on Medicare. We can do more for people with commercial insurance. But I think for patients, especially those who are seriously ill, $2,000 may be better than $5,000, $10,000, $15,000 out of pocket that they needed to find. Just another comment on the Medicare prescription payment plan. I'm not a lawyer. I'm not reading it the way you are. If in receipt of that bill from the Part D plan, it's not paid within 2 months, then the Part D plan may, in fact, ask that individual to leave the Medicare prescription payment plan, but they're not going to kick them off of the Part D plan. That's how I'm interpreting it. And I think we have to remember that this payment option is not for everybody, right? I mean, everyone has the opportunity to review it and decide for themselves whether it's right for them, but it's especially helpful if that individual has spent or is spending more than $2,000, let's say in the first 9 months of the year, or they have a single prescription fill of $600 or more, or they don't want to pay everything up front in one lump sum, they would prefer to spread those costs out, or they're not eligible for the Extra Help program. And by the way, we have 3 to 4 million people in this country who are eligible for Extra Help and simply do not know that that program exists, or maybe they're not eligible for a grant from a foundation like the PAN Foundation. So it's not for everybody. It may be particularly helpful for 1 to 2 million individuals with high costs.
Julia?
I'll just add, as a part of the Inflation Reduction Act, this happened a little bit earlier, I believe last year, but there used to be partial and full Extra Help. And the Inflation Reduction Act actually expanded it, so all of those who originally qualified for partial Extra Help now qualify for full Extra Help.
Julia, I want to ask you a follow-up. You mentioned scams, and seniors are constantly targeted for scams, including Medicare scams. Has that been an obstacle? And ask you, but also weighing in with the other panelists, what would you like to see CMS do more of? Because, a lot of people don't answer their phone now, or they think, okay, maybe this is a scam. I haven't heard about this. It's not in the papers every day. What do you think about that?
Yeah, I mean, there's the trends are always changing, but there are a lot of scams in terms of people calling to offer free genetic testing or durable medical equipment. And I would actually say that there are a lot of concerted efforts across a lot of various federal agencies that are coordinating to try to make older adults aware that these scams are happening, helping them learn how to prevent it, and also getting the information that is needed so that they can be investigated or passed over to another federal agency to look across the aggregate in terms of the large trend that is happening and who needs to be held accountable to make it stop.
Anyone else who wants to weigh in on what the federal government should be doing more to say, hey, you've got to pay attention to this?
It's always difficult when we're here to talk about IRA, and I'm raising the broader issue of rationing in the healthcare system. But if you look at coverage with evidence determination, if you look at CBO scoring, if you look at the ESRD bundle, if you look at access to immune therapies, across the board for poor people, they don't have access to that stuff. Let's be really blunt about it. And so, yeah, you can do a $2,000 here, and you can do a little smoothing over there, but at the end of the day, their life expectancy is shorter. That's why we can go into a zip code and tell you how long you're going to live. That's why. Because the system is structured to ration care to poor people. Period. Not a lie, right? And what we're saying is we want evidence-based medicine for everybody. Everybody has to follow the science. You CMS, you Congress, you doctor, you patient, everybody follows the science. That is the best way to get outcomes for everybody, right? And we can pay for it because there's $4.5 trillion on the table, scheduled to be $6 trillion in 2030. That's a hell of a lot of money. Hell of a lot of money, right? For the kinds of outcomes that we are producing. It's unconscionable that we permit that. Unconscionable. That's my position.
Amy, what about the role of other stakeholders, providers? I know you have a guide on. Can you talk a little bit about that and their role in educating beneficiaries?
Yeah, I think several stakeholder groups are really critical to this equation. So we're trying to reach the person on Medicare, but that healthcare provider is a trusted source of information for that individual. So the healthcare providers, physicians, nurses, PAs, nurse practitioners, and so forth are in a wonderful position to make sure that the patients that they are caring for are aware that important Medicare reforms are coming their way. working with community-based organizations. We're doing a lot of work at the community level, for example, in Atlanta and in Dallas, trying to collaborating with the local CMS office and educating the people in the community about the IRA in general and the Medicare reforms, because as I said, very, very low awareness. So I think to your question, we're all in this together, and there's a role for all of us to play in educating people on Medicare about, in particular, the Medicare prescription payment plan and the importance of open enrollment right now, which goes through December 7th.
Right?
Absolutely.
Just on sort of on the education question. So as I mentioned, I was at CMS when the Medicare Modernization Act was passed, and sort of helped with the implementation of it. And I remember a story that was told to me by a colleague who somehow a phone call got sorted to him. I don't quite know how this happened, but at the time there was really a lot of, there was actually a bus. If we think back to like 2005, fall of 2005, there was a Medicare bus. There was a lot, Medicare.gov. There was a lot of advertising that CMS was doing around the Medicare drug benefit. And to the point that they had there was a Medicare blimp, which I think, if you guys remember that, which was actually at I think would be at like the SEC football games, right? And so what happened was, I think somebody called and was complaining because I was watching Alabama versus Auburn or whatever it was, Alabama versus Georgia, and I saw the blimp, and I'm like, why is the government spending money on this? And it somehow got to this person that I was working with. But I bring that up because I don't know that I've seen, and maybe it's coming, and I just haven't seen it yet. So I don't know this for certain. But we're in open enrollment now, and I don't feel like I'm seeing like that kind of educational push from the federal government around kind of pushing out. And maybe it's coming, and maybe I just haven't seen it. So I don't want to.
But it's getting late in the game.
But it's getting kind of late, and I don't feel like I've seen it. And I watch a lot of college football, and I just haven't seen it during college football games.
Seen it.
So, I haven't seen it on Saturdays or Sundays, which is when obviously a lot of people are watching TV. So, especially in this day of, streaming and everything, it's kind of like the live sports is sort of the last sort of time to kind of get people where they're, when they're actually in their seats. So I feel like that's something that I guess I would like to see more of. I think that's, I do think there's a risk for, people getting misinformation, people getting, scared about different aspects of it, and, making a decision that's maybe not well informed. And I do think that I'd like to see, sort of more from CMS here if I'm kind of thinking about what I think sort of needs to happen personally.
Because the blimps worked.
Well, it definitely, it worked.
We remember it 20 years ago.
We remember it 20-something years ago, right? Remember that, and people probably remember the bus, and I realize some folks here, were probably pretty young when that was going on, but nonetheless, it was effective at the time, and I don't know that I'm seeing that kind of level of commitment, at least to an educational effort from this administration that I remember seeing from the what was at the time the George W. Bush administration.
I think you're right. Generally speaking, you're not seeing it. There are no blimps. And I'm skeptical that we will see much in coming months, which is why the Alliance for Aging Research and PAN and other groups are doing all we can to reach our stakeholder groups with this information, because it's important for them to have.
We will open it up for questions in just a bit. Obviously, the election is 2 weeks away. The IRA has been very polarizing on Capitol Hill. As I mentioned in my discussion with Bruce, Republicans want to repeal it, but that could prove to be difficult. And Republicans say they want to learn the lessons of Obamacare, which didn't work out so great for them when they tried to repeal that. Can anyone just talk about the noise, the polarization, and how that's affecting, and what will the election mean going forward, especially with a second round of negotiations?
I'm so glad you raised the question of elections, because in the community that I work in and live with, we've been put on a fire alarm. Democracy's at stake. You have to get in line. Everybody. If it's 2% difference, you're not doing your job. But then when we turn around to healthcare, right, and we look at those healthcare numbers, right, they don't reflect what you asked us to do. And the general feeling where I come from is that we're done with that. We want quality healthcare in our community. And that's why I'm saying to you, everybody has to follow the science. Everybody in the system, because if we do that, I think we get to equity. I think we get to where we want to be, right? Because the science is incredibly important. We are learning how to do fabulous things. What is going on in cancer is what Nixon imagined when he started the war on cancer. We are going to control cancer, period, flat out, right? But can we deliver that to marginalized communities? Not what we're doing right now. And so we feel reciprocity. We're going to vote, but come 2025, we want to see something different. And I think all Americans should ask that question, because that $4.5 trillion that everybody's talking about, that's your money. That's what every American household kicks into the kitty. It doesn't come out of the sky. It doesn't belong to anybody. It belongs to the American people. And then you turn around and say, well, we can't give you quality health care. We got the worst in the world. What the hell? Come on. You can't come back and say, I gave you $4.5 trillion, but you're going to die because I can't figure out how to get it to you. That's insanity. So in the communities that we work with, we're saying the moment of truth has arrived. We have lived with segregated health care since the American healthcare system was formed in the 1940s. We've lived with that. We know exactly what that looks like. And we're not doing that anymore. Right? So I'm just telling you how people feel, just being upfront with you. And that's what this election is about. Obviously, it's about our democracy, but it's also about making sure it's our social contract. You know, when Jefferson wrote Life, Liberty, the actual first word was conservation of life. That's our social contract. That's what we pledged to each other that we were going to do. And the moment is now to do that because we have the science and the capability. You don't even understand what we are capable of doing. It's unimaginable, unimaginable. But we got this healthcare system, that healthcare financing system, that's really the problem, that can't really deliver the goods. So anyway, I'm gonna stop.
Why don't we open it up for questions? We've got a mic. Just wait for the mic and just identify yourself and brief question.
Greg Pugh, I wanted to follow up on something Tom said. I was at HHS a little after you were, so I did not get on the Part D bus, but I did have the souvenir bus in my office. But I was there during the Affordable Care Act, and whatever you think about that, like I don't think that that's thought of as a public relations success necessarily, at least not originally. And then 15 years later...
Not an implementation success either.
Yeah, fair. And then 15 years later, we're here and, 7, 8, 9, 10 out of 10 Americans don't know about this other thing. And so if Gary doesn't get his wish and we continue to have CMS messing around in the healthcare system and making these increasingly complex tweaks to the system around the edges that require a lot of patient knowledge that isn't... Do we need to rethink the whole paradigm of how people find out about this? Because I mean, the work you guys are doing is great, but it doesn't seem like it's a sustainable way to do it.
This is my personal view. My personal view is I think when the government implements a policy, they need to lean into it and they need to follow through on it, right? And I think that's what, I don't know, this is my personal view. I'm not seeing that kind of commitment from CMS that I saw in the Medicare Part D program when it was implemented. Right, and I think it's unfortunate. I don't know why. I'm an independent consultant, not in the administration, but I feel like that's a missed opportunity. And I personally would like to see kind of more commitment. I I don't know why that's not happening, but from my knowledge, I think that kind of, I didn't see that with the MMA. I saw, we passed this and it was controversial, and it I think only in the House, I think voted mostly just Republican votes, right? So, it was seen as partisan in a lot of ways too, right? But they leaned into it and they really kind of pushed it forward, and they were not shy about the kind of communication around it. And I don't know that I'm seeing that with the IRA. I mean there are public information sessions, but I mean in terms of the actual beneficiary outreach and kind of a strong advertising outreach here, I'm just not seeing it. And I was kind of waiting to see, will I see it? And I don't think I'm going to, and I think it's unfortunate.
You will find information about the Medicare prescription payment plan on page 87 of the Medicare and You handbook. And I'm saying that facetiously. It's hard. It is hard to find, and maybe 1 out of 2 individuals on Medicare actually open up that handbook to review it. So to your point, I think you're right. It's more is needed.
It's hard to find on their website, despite it being the major initiative right now. So, sorry. Okay.
Hi, Rosamund Katz. I had been working in health policy in federal government, but now I'm a volunteer at the Montgomery County SHIP office. So I really have learned to appreciate the difference between health at the 30,000 foot level, which is most of the people, and then really talking to beneficiaries every week. A couple of small things first is the $2,000 cap is on drug costs. It does not include premiums, is my understanding.
Yes, that's right.
Drug cost Part D.
Drug cost Part D.
Right. This is in the standalone plans.
And the Medicare Advantage Part D plans too, right?
Right. And I don't know how many people are bumping up against the $2,000 maximum. There are a lot of people, I'd say the vast majority, whose drug costs are going to be far less than $2,000. So, it's a policy. Everyone's going to think they've gotten this great gift, but doesn't really help them. It helps a select a few people. So the other thing is this MP3 business does not reduce costs. It spreads costs over 12 months instead of having it hit you in January and February. And a lot of these plans have $590 deductibles. Yeah. So that and a high tier medication is going to hurt some people. And this will help them smooth it out. If you are low income, the better thing is to seek the extra help. And that has become more generous over time. So that's on the technical things. But one point I wanted to convey is I talk to people, this is not only during open season, but throughout the year. And they say, why do I have to revisit this every year? I don't want to. I don't want to spend the time. I'm afraid of making a bad decision about my Medigap or my MA plan or something else. It's like homeowners insurance. You want to buy it and forget it. And here we are talking about spending more resources on educating people because of this instability, because everything is constantly in flux, and we're asking seniors and people with limited interest and ability to constantly make a really, really important decision for themselves.
Anyone want to? I just want to get to more questions. Yeah, anyone want to tackle that?
Yeah, I just want to say the average out-of-pocket cost that Medicare beneficiaries pay annually is somewhere around $700 to $800 a year. On average is what they're spending out of a total out-of-pocket of $8,000, right? So that's the number that people are working with. And to your point, that's why the $2,000 doesn't really touch a lot of people.
But I'll add, while you're right, it doesn't touch everybody, but you never know when your healthcare provider is going to give you unfortunate news about a chronic disease. And so if and when that should happen, knowing that your out-of-pocket will be capped at $2,000 is a good thing.
And I do want to point out quickly, the Medicare Advantage plans do have a out-of-pocket limit. I don't remember what the maximum is. I feel like it's $8,900 or something, but that's on total medical costs. So there are protections in Medicare Advantage, at least on a Medicare out-of-pocket limit, and obviously the $2,000 out-of-pocket cap for the drug costs as well.
Go back of the row.
Good morning. Regarding public relations, I just wanted to bring a couple of things to the forefront. During the first open enrollment period of the Affordable Care Act, there were some fraudulent activity and some miscommunication to particularly marginalized communities. And so I want to know if there will be funding that will help to combat some of that kind of activity that could potentially take place targeting our elders as it pertains to this initiative. And if so, and one more thing I wanted to add, it was the navigators that you all funded who helped to educate and to bring to the attention of CMS that fraudulent activity that was taking place. And so I'd like to know if there will be funding as it pertains to Medicare, the Medicare drug benefit, so that there won't be this kind of activity taking advantage of our elderly population, particularly those in marginalized communities who were the most targeted. Thank you.
Anyone want to tackle that? Julia?
So for us, the Senior Medicare Patrol is a program dedicated to educating older adults about scams, fraud, and abuse, and then helping them report it. That's a program funded through the Administration for Community Living and works very closely with CMS and OIG in order to handle the cases of the issues on an individual level or on a broader aggregate level. So that program has been around for a while, and it continually adapts as these new scam activities evolve.
Yeah, one more question. I think one more.
Hi, Zach Schultz. I was wondering, we talked about the sort of the political implications with the election and going into next year. And I know there are efforts, particularly around reforming the small molecule, like how long before small molecule drugs can be included in the prescription drug negotiation. Do any of you foresee opportunities within Congress, regardless of how the election goes, to make tweaks to the IRA as we move forward?
Can I start? I feel like it's hard to predict what could happen until we know the outcome of the election. I think, just given kind of, House, Senate, White House, and in terms of, how the vote goes. So I think that'll, to me, sort of guide, obviously the Kamala Harris has talked about wanting to negotiate more medications. I know former President Trump's talked about negotiation in some form. So I feel like it's a little challenging to know kind of how that will play out until we sort of know the election, until we know broadly the election outcome. At least that's kind of my take on it.
Anyone else have a thought on?
The question you asked really cuts to the heart of the problem, really. When government steps in and starts setting price controls, you get all kind of oddities into the system. So small molecule versus large molecule. I mean, really, it's in my mind, it's like I go to a car dealer and the federal government is now setting the prices for cars, right? It's very, very difficult in an economy to set value outside of the competitive market space. And what CMS is doing, so it sets prices for hospitals, it sets prices for doctors, it now wants to set prices for drugs, right? And when you go and you look at what is happening, you see all of these inequalities, structural inequalities in the system because of the policy. And what adds to it is that CMS is not outcomes-based. It's not saying, am I reducing hospitalizations for people with diabetes? Am I using these new cancer therapies to increase life expectancy for people? It doesn't have those kinds of measurements. And we need those kinds of measurements down at the community level so that we can get the best possible outcome for patients. So I know I'm ranting and raving about government price controls, but there's a reason for it. Because when you go and you look at the data, you see year after year populations with shortened life expectancies, higher hospitalization rates, poor quality of life, right? For a program that we, the people, are paying for. And we're saying we don't want to do that anymore. We just don't want to do that. And we want to give ourselves permission to reimagine the system, because the question that you really should be asking, do you want this system in 2050? Is this what you want to have? Is this the conversation you want to have in 2050? I think that's ludicrous. Really, I really do. And so it'll be difficult, it'll be a journey, but I think we got to start the journey by saying to ourselves, we got to give ourselves space to reimagine. We want payers to help us reimagine. We want Medicare Advantage. Tell us what's going on. How can we help you? We want the doctors to reimagine. Tell us, what do you need, right? We want patient advocates to be at the table. That's our future. This stuff comes out of the 1920s. I mean, the 20th century, right? It's not 21st century medicine. Think about it. We could use AI. Do you want CMS using AI? Raise your hand if you want CMS using AI. Well, you don't. You don't want government in there doing God knows what. I'm just being candid with you. So when you look at the operating reality that we have, that system can't take us into the future. It's an old model.
We have run out of time. Please thank our panel for joining us this morning.
This concludes our program. I just wanted to thank all of our fantastic speakers and Bob for hosting. I also want to thank our sponsors, Alliance for Aging Research. And on behalf of the Alliance and the Hill, I'd like to thank all of you for attending, both in the room and online. If you missed any portion of this, everything can be found on thehill.com. Have a great day. Thank you.